And I'm going to say hello. My name is Sandra Arevalo. I'm the Director of Community Health and Wellness at Montefiore Nyack Hospital. And today in Community Chats, we have a very special guest who has been with us in prior seminars. And his name is Aaron Salwin, and he's one of the pharmacists here in the hospital. We're very happy to have you. Thank you so much, Aaron, for being with us today.
Of course. Thank you for having me.
And today we're going to be talking about opioids. And just before we started, we were talking about how popular they are becoming and how not good this is. And he's going to tell us why, and he's going to give us a little bit more insight as to how we can be ready in case someone out there that we know might be induced to start using opioids or is already using opioids, which is, of course, a very delicate situation to be in. And at this point, I would like to invite all of our attendees to please interact with us, send us questions, comments, stories, anything that you would like to share. And all your questions will be answered. This is a great opportunity to actually ask questions without having to make an appointment with a doctor or a specialist or anything like that. This community chat is for you. This is your space. So please, attendees, just use the Q&A, the chat, any way that you feel comfortable sharing with us, and I will read all your comments and questions to Aaron for answers. So without further ado, Aaron, tell us a little bit about you. You were just telling us before we started the recording that you were living in Tennessee. So why don't you tell us about that again and how you became a pharmacist?
Sure. So I went to pharmacy school in Ohio. It's where I grew up, where my family's from. Graduated pharmacy school in 2017 at Ohio Northern University. Then right after graduation, I moved down to Johnson City, Tennessee for a 3-year research fellowship, looking at the pharmacist role in mitigating opioid use disorder related problems. And during that time, I received my master's in public health with a focus in community and behavioral health at East Tennessee State University. And so during that time, I had a lot of exposure to working with patients with both substance use disorders and mental health conditions. So I thought it'd be a good idea to pursue additional training in psychiatric pharmacy. So I did a 1-year psychiatric pharmacy residency at Rutgers. And then I've been here at Nyack for a little over 2 years as a clinical pharmacy specialist in behavioral health. I work predominantly on our inpatient behavioral health unit, as well as in the emergency department. And I spend a little bit of time each week on our inpatient detox and substance use disorder unit. So we take care of patients with all sorts of mental health conditions, ranging from anxiety or depression to schizophrenia or bipolar disorder. And also in our inpatient substance use unit, we work with people struggling with alcohol use disorder, opioid use disorder, cocaine and other stimulant use disorders. It's my role to help the physicians come up with an appropriate medication regimen. I'm cautious in looking for medicines that could be dangerous or have interactions. And also, I spend a lot of my time educating patients in a group setting, whether that's the behavioral health groups that I do focused on medication and lifestyle changes, as well as our substance use population, where we talk about the different medications that could be helpful in helping people to reduce their problematic use of substances. But even though I'm a pharmacist, I talk a lot about the non-medication things or the non-pharmacological approaches to dealing with both substance use disorders and mental health conditions. So I'm really passionate about this topic. It's something that I've had a lot of training in, and I've worked with a lot of different professionals regarding this topic. So I'm happy to share what I know and to answer any questions that you may have during our time.
Thank you so much. And what an extensive curriculum. And now, you know, you're in trouble because you just mentioned a couple of things there: depression, schizophrenia, bipolar disorders. We're all eager to learn about that as well. So you're being invited to at least 3 more. communicate
Yeah,
that.
Sandra,
Don't worry, it will be 2024. It's okay.
you keep me busy, that's for sure. No, it's my pleasure. It's a
I'm
lot of
so
fun.
sorry, but you know what? The thing is, what you do is very specialized. There is a lot of curiosity around it, and a lot of people want to learn more about it. So, your problem.
Yes. Well, that's kind of
Yeah,
what has drawn me into this. I find it to be very interesting, and it's very challenging. But it's fascinating. It's a lot of fun. So
it is. It is. Okay, so I'm
all
gonna
right.
let you do your presentation. Thank you so much.
Okay, thank you. So good afternoon, everyone. Yes, I just have less than 15 slides together that I put together, which I think encompass the basics of opioids and opioid use disorder. So I will share a little bit on each slide, and I hope that I'll leave plenty of time for questions and discussion. But if you have any questions as I go along, please don't hesitate to stop me, and I'd be happy to answer any questions as we go. So first off, I thought we would start with what is an opioid. So opioids can be referred to as our prescription painkillers. And a lot of times these medicines are prescribed after surgeries, maybe following an accident, or they're sometimes used during surgeries for anesthesia purposes. But the essential purpose of these medications is for short-term pain control and pain relief. What we found, I think, over the past 15 to 20 years is that if people end up taking these opioid medications, even as prescribed, they tend to lose their efficacy in terms of pain relief and tend to cause more problems for people as their body becomes physiologically dependent to them. So common opioids that are prescribed, hydrocodone, which is the active drug or one of the active drugs along with Tylenol and Vicodin, methadone, which we think of as a first-line agent for treating someone with opioid use disorder, but it's also a very potent pain reliever. And then, of course, oxycodone or Oxycontin. And our kind of status as we are now in terms of the opioid epidemics really can be traced back to the release of Oxycontin. Prescription or the pharma companies, the prescription companies kind of marketed this drug as a cure-all for pain. And their solution to the medicine not necessarily doing its job at relieving pain was to simply prescribe more. And that kind of led people to become more and more dependent on this substance. And as access to this substance became less available, then people had to seek alternative routes to manage their pain. And we'll talk more about that as we go through this presentation. But essentially, these medicines are great at relieving short-term pain, but can cause some problems if they're used for an extended period of time. And although they're useful at helping with pain, they don't come without any side effects. So even if someone is taking these at a prescribed dose from a physician, tolerance can develop. So that's what I alluded to earlier as the need for more and more medication to get the same desired pain relief, which also can then lead to a physical dependence, which is different than addiction. Physical dependence occurs when the body has just accumulated and acclimated to the use of a medication, and without it, the body can develop a withdrawal syndrome. Now, opioid withdrawal is, I've heard it described as one of the most uncomfortable things that someone can ever experience. Compared to alcohol withdrawal or benzodiazepine withdrawal, opioid withdrawal does not appear to be life-threatening, but it's very, very uncomfortable, and people I've heard them describe that they wish they were dead, but it usually does not result in any mortality, but it's so uncomfortable that a lot of time there is a return to use. Constipations, opioids, as they work in the body, they work on something that's called the mu opioid receptor. And there are these receptors all throughout the body. They're in the brain, but they're heavily present in the GI tract. So if someone is taking even doses as prescribed of opioids, it can really slow down the GI tract and cause constipation, which can be uncomfortable. Nausea, vomiting, dry mouth. Some people, even if, let's say, they're prescribed a short course of opioids, some people have poor reactions where they can't even tolerate it, causes really an upset stomach or vomiting. Sleepiness and dizziness. So this is these medicines kind of can produce this calming effect, which this sleepiness is sometimes euphoric to people, and that's what draws them to continue using. Confusion, depression, we find that people who are maintained on chronic opioid therapy for years or for an extended period of time are more likely to develop depression and other mental health comorbidities, low energy, low sex drive, and then opioid medications can also cause an itching or even a sweating feeling. So yes, we can see that they're very useful in managing a short-term pain, but they come with them a lot of potentially uncomfortable side effects. Now, in terms of taking this even a step further, let's talk about what happens in an opioid overdose. So something that I see truly on a daily basis, especially if people are suffering from opioid use disorder, they may have been involved in some type of accident where they were prescribed an opioid. The dose continued to rise until the person became dependent on them. The United States and government agencies, predominantly the CDC, have attempted to address opioid overprescribing by requiring physicians to limit their prescribing to a certain dose. But this kind of cut down on opioid prescribing has forced people to seek pain relief elsewhere. So, as I mentioned, we have opioid receptors all throughout our body. And in the setting of an overdose, the opioid receptor in the brain becomes overwhelmed by the amount of drug or the amount of opioid that the person has ingested. And essentially, this opioid is turning off the signal in the brain that tells the body to breathe. And so when someone is experiencing an opioid overdose, they are experiencing a respiratory depression. So they're not getting the signal from the brain that they need to breathe. So when that happens, we may find someone to have very shallow breathing, 2 or 3 breaths per minute, if that. And in the case of a true overdose, their breaths per minute may not exist at all, and that it leads them to be unresponsive. So this is, I think, useful to understand when we'll talk later about how naloxone works, and also how treatments for opioid use disorder are slightly different and can be effective. Now, as I mentioned, when someone is experiencing an opioid overdose, they're not getting oxygen because they're not breathing. And so it's important to quickly identify this if you suspect someone may be experiencing an overdose, so we can get them the appropriate care. So one thing to look for is clammy or pale skin. I mentioned that they're also not getting oxygen because they're not breathing deeply enough. So this lack of oxygen can cause the skin or the lips or the fingernails to turn a grayish blue color, indicating they're not getting oxygen. Opioid intoxication, or meaning someone who has taken an opioid, will have pinpoint pupils, which, as this figure presents, it's a very kind of small pupil. And that is a useful sign to determine if someone has had an exposure to opioids. Their heartbeat is going to be slow. They may have, as I mentioned, slow, irregular breathing. But the biggest one, which I think is the most important, and when I'm educating people on how to use naloxone, I always say, check to see if the person is responsive or not. Now, ways to do this are to shout the person's name really loud, to shake their shoulders. A tip that I like is to take a fingernail and dig it really deep into the earlobe. You're not really doing any damage there, but it's enough of a pain sensation that it may cause them to wake up. In terms of, we'll talk about responding to an overdose, the really only effective intervention that we have is using Narcan or naloxone, which is an opioid antagonist. And we'll talk about how to respond to an overdose once we've recognized it. And of course, calling 911, and we'll go through the steps here in just a moment. But the reason, we're talking about this as the number of overdose related deaths continue to rise. So usually most statistics related to opioid overdose deaths will start around the late 90s or early 2000s. But as we can see, especially impacted by the COVID-19 pandemic, overdose deaths by any substance are continuing to rise. This next slide here indicates kind of what I was talking about initially. Is once we had the development of these kind of potent opioid painkillers and prescribing started to increase. Initially, in this first wave of the opioid epidemic, we had people who were most vulnerable to prescription opioids. Then around 2010, things started to get dialed back. We started to have some regulation to reduce the number of opioids prescribed. And that diverted people or forced people to look elsewhere for pain relief. And so as you can see, the overdoses related to heroin kind of begin to rise. Now, in around 2013 and into this present day, you could extend this arrow further to 2023. The overdose deaths are primarily driven by synthetic opioids, predominantly fentanyl. So fentanyl is an opioid. It's used predominantly in medicine to manage cancer-related pain and also in surgical procedures for anesthesia. But fentanyl is 50 to 100 times more potent than morphine and more potent than heroin. And what we're finding is that it's produced very cheaply, usually in labs in China, and shipped over and comes into the United States through Mexico, predominantly through cartels. And this fentanyl is being added to really all of the heroin supply. If you talk to people who are using opioids, they'll tell you that it's very difficult to find heroin. The majority of the heroin has been replaced with fentanyl. And another aspect of fentanyl that I think is potentially dangerous to people is fentanyl comes as a powder, and this powder, this powder can be pressed into tablets or pills that are identical to other drugs, other prescription drugs, and sold as oxycodone or sold as a Xanax or Percocet. But in reality, this substance or the drug, the tablet that's being purchased contains fentanyl and likely other adulterants, other substances. And when people are preparing this for distribution, they are not their what should I say, their contamination control, their ability to regulate the amount of fentanyl that's in each dose or in each bag is poor. So someone may purchase from the same dealer and receive vastly different concentrations of fentanyl in each product. So fentanyl and other fentanyl analogs are really driving overdose deaths to this point in time. And this is another kind of variation of that graph, pulling out overdose deaths and looking solely at opioids. And as you can see, opioid deaths opioids were responsible for over 80,000 deaths in 2021. So that number continues to grow. And like I said, it's largely related to fentanyl and its analogs. Here's just a visual here indicating that. And so as fentanyl is so powerful, Sandra and I were talking about this before we began, very small amounts of fentanyl can be fatal. We're talking about like grains of salt. So if someone is exposed to this without that tolerance, without their body's ability to handle this potent substance, then they're much more vulnerable to experiencing an overdose. Another occasion where folks are very vulnerable to overdose is leaving prison systems or jails, or after being incarcerated, after leaving drug treatment programs. So, excuse me, so time away from using this substance changes the brain chemistry, and the brain, which once had some resilience towards handling high doses of fentanyl, kind of resets, and the brain is much more vulnerable to overdose after a time of not using the substance. So for instance, let's say we have a 4-week inpatient rehab program. People are refraining from using any type of opioid during that time. They are released, they have a return to use, and they go back to using their usual dose. Well, their usual dose is much more powerful than what they can handle at that time, as their body is kind of adjusted to not having opioids for a significant amount of time. And also, I wanted to mention, fentanyl has kind of made headlines about how people are touching it and overdosing and dying. And I just want to dispel that myth. It's not a true thing. In order to have the ill effects of fentanyl, it has to be ingested or injected or snorted, but simply touching it is not going to cause problems. And a good way to think about this is we use fentanyl patches to manage cancer pain, and that patch has a lot of technology into it. If it was as easy as sprinkling fentanyl on someone, drug companies would not spend millions of dollars trying to formulate this technology to deliver the drug. But that is a common misconception, and something I like to talk about with people and patients. So, we mentioned all of these seemingly uphill battles with opioids and opioid use disorder, but there are prevention efforts that are underway and are evidence-based at reducing harm associated with opioids and opioid use disorder. One way to break down prevention is into primary, secondary, or tertiary prevention. And so primary prevention is preventing the initial use or delaying substance use when a problem does not yet exist. So from a clinician point of view, we may look at family history. We may see, well, if this person has a strong family history of addiction or substance misuse, we may know that they carry the genetic makeup that puts them at a higher risk of, if they are exposed to an opioid, they may develop a drug liking, which could turn into a use disorder. Our secondary prevention is early detection or reduction of substance use once a problem has already begun. So this is simply a screening of seeing if someone has begun to develop a substance use problem. We can ask them about their use habits. We can ask them their relationship with the substance, how they feel that it impacts their day-to-day functioning. And if we identify some signs that this is maybe headed in the wrong direction, we can refer them to treatment. And then lastly, tertiary prevention is reducing substance use problems or harms to prevent further deterioration or death. So this is where medications for opioid use disorder come into play, as well as you could lump naloxone or Narcan into this category as well. We're trying to reduce harm. We're trying to keep people alive. When you talk to people about substance use disorders, a lot of times they're at that contemplative or pre-contemplative stage of change where they're really not interested in stopping. They're going to continue to use, and as we mentioned, a lot of times these people that are using opioids have significant pain, and they maybe have tried alternative routes, but opioids are, at least for now, the only thing that's managing their pain. So we try to meet people where they're at and keep them alive. We can be there for that person during their use, try to provide them with the resources to keep them safe, to keep them healthy. And then over time, there may be a point where they elect to engage more in treatment aimed at maybe a goal of abstinence, or if not abstinence, of reduction of use. And so there are all sorts of different harm reduction techniques that clinicians are trained in, and I, as a pharmacist, try to spread to our treatment team and patients, really just to keep people alive. Very common to see people in and out of the hospital related to substance use disorders, and it's easy to see that the patient may hang their head. They feel like they've failed, they've let someone down. But the best thing that we can do is just say, I'm glad that you're alive, and let's try again. So Narcan, or naloxone, is a huge potential weapon we have to fight against the opioid epidemic. So as I mentioned, Narcan, or naloxone, this is a nasal spray that can reverse an opioid overdose. And it's currently, just as of recently, available over the counter without a prescription, and not even behind the pharmacy counter. You'll see it. Most pharmacies, I believe, will carry it. You walk into the pharmacy, it should be right out in the aisles, able to be purchased without a prescription. Each one of these nasal sprays is one dose. And the majority of patients after an opioid overdose will respond to one dose. But each box does contain 2 of these sprays. And I wanted to talk a little bit about how it works, so we can kind of get an understanding of maybe a little pharmacology, but also rationale as to why this is important.
And
So,
Aaron, we
go
have
ahead.
a question here.
Yes.
It says, I think it's about that myth that you were talking about, that people think that by touching the fentanyl, they were already gonna, I guess, absorb it. It says, can you explain why some people pass out when they come in contact with fentanyl?
It's a really good question. And yes, this is something that, like I mentioned, has made headlines, where a police officer has fainted, has passed out, even to the point where they've required emergency care. However, it's hard to say without having been there, but my assumption, and what the experts who have weighed in on this indicate, that there's a lot of fear, there's a lot of anxiety, there's a lot of catastrophizing what could happen if there's a fentanyl exposure. So I don't want to entirely say that there wasn't anything medical going on, but it's possible that the fear response, the expectation that an overdose was imminent, caused the body to have this reaction. Of course, the mind and body are related heavily, so expectation can manifest itself in a variety of different ways. But in terms of true fentanyl exposure, just brushing up against it or touching it is not enough to have it absorbed in any type of dose, and especially a dose that would cause an overdose.
And we don't know, it might be also possible. I'm thinking that people might have a reaction not just to the fentanyl, but something else that is next to the fentanyl, or we all have different allergies, for example, so maybe some people might react differently and more stronger than others.
Yeah, it's a really good point. It's a really good point. And I think the news sources kind of ran with these exposures, and now people are really hesitant to even interact with, or this type of language and broadcasting may deter people from assisting in an overdose situation. So I think it's clear it's important to understand that whatever was going on was not related to just the fentanyl being absorbed through the skin and causing an instant overdose. But yeah, it's a really good question.
Yeah, and I think that talking more about this myth, then it can help people relax a little bit, because again, it could be an anxiety attack that is creating it, like, oh my God, I touched fentanyl, I'm gonna die, and die from the anxiety attack and not the fentanyl itself. So it's a good thing that we are talking about this as a myth, so that we can help educate the public as to how to react, and that they can be, okay, once they touch the
Yes. Definitely. I think so. And even people that are using fentanyl or using opioids oftentimes have that misconception. So that's an opportunity for me to say, well, hold on, let's think about this and talk through the science of it. And that tends to give people a little bit of a sense of relief that, that this substance is very potent, but just
You don't
minimal.
need to die right away from it.
Right.
Yeah.
Exactly. Exactly.
The person who asked this question says, yes, I agree, especially to help teens and parents understand, right? Yeah.
Yeah, absolutely. And speaking of teens and parents, it does seem that the widespread availability of fentanyl and the fact that it's making its way into the recreational drug supply, we're finding, and there's research to support this, that adolescents and teens, their first drug of use, which was predominantly in the past years, maybe alcohol or cannabis, is shifting towards opioids. So I think that is a problem for teens growing up. They're unknowingly or knowingly getting exposed to very potent opioids fast or at an early age. And the amount of accidental overdoses where we see young people who they believe they're taking a substance, a pill that does not contain fentanyl, and in reality it does, and that causes an overdose. That's more of a call to have naloxone on hand, to have Narcan available in case of this type of emergency.
Thank
So
you. I let you continue with your
okay,
presentation.
thank you. So just a little bit more on naloxone. When someone, as we talked about, the opioids are binding to your opioid receptor, and that causes respiratory depression or turns off the body's ability to breathe, essentially. Naloxone, as you can see in this picture, displaces or kicks off the opioid from this receptor, which is essentially allowing the person to breathe again. So in an overdose state, we find someone who is not breathing, they're unresponsive, they're lying flat. With naloxone, it tends to produce a pretty rapid return to consciousness. It may come with a large breath or a gasp, and the person is alive and functioning again. What does happen in this instance, as naloxone is displacing the opioid, is the person will experience a precipitated withdrawal that is very uncomfortable and tends to be largely unpleasant, but is temporary, and the person is alive. So when I'm educating people, I'll say, the person's going to wake up, they're not going to be feeling well, they're going to be nauseous, they may have some diarrhea, they're vomiting, they may be disoriented to where they are, to what's been happening. So the best thing that you can do in that situation is to kind of orient them to what's been going on, to where they are, and to assure them that what they're feeling, although it's uncomfortable, is temporary, and you're going to try to get them some extra attention or help. So what I'd like to do next is kind of walk everyone through on how to truly respond to an opioid overdose. So as we mentioned, we're looking for signs of an overdose. And if we're not sure what the person is taking, like if we don't know if they're using opioids or not, naloxone should still be administered because it's very safe. If someone has not ingested any opioids or doesn't have any opioids in their system, it's completely benign. So me currently right now, I don't have any opioids in my system. If I were to spray Narcan up my nose, I would just have a soggy nose and that would be it. So when you first see someone, you want to assess if they're responsive or not. People who are using opioids in high doses oftentimes are very sedated. They may be experiencing what is referred to as a nod, which is just as it sounds. They're nodding their head. They're not able to keep their head up. Narcan is reserved for people who are truly unresponsive. So you want to assess that. if you administer Narcan when someone is using opioids but is not unresponsive, it's going to still send them into a very uncomfortable withdrawal state. It's possible that they would have recovered from the intoxication without requiring naloxone. But you want to check to see if they're responsive or not. So when you come upon a person, you check for responsiveness, and then your next step is to call 911 and administer naloxone, whatever you can do fastest. If you have the phone on speaker, put it on speaker and administer naloxone. You want to stay with the person after you've administered Narcan. If you need to leave the person to go get help or to get a phone, you want to place the person on their side. This is what we call the recovery position. As patients, once they're revived, they oftentimes are sick, so we want to avoid them from choking, or which can lead to aspiration, which can be not the best thing. And you want to stay with the person. There are several instances where one dose of naloxone is not enough. So if you administer naloxone, you should see a response relatively quickly, within about 2 to 3 minutes. And if you don't see a response in that time, administer another dose, and you can really just continuously repeat this process until the person comes back. The time unconscious or the time without oxygen is very important. If the brain doesn't receive oxygen for 4 to 5 minutes, that's when we start to have permanent damage. So we want to get the person back as fast as possible. And another reason for having naloxone in the community's hands is police will get there first usually, but it's still always not instantly. It can take them 7 to 10 minutes on average for them to respond to a 911 call. So that, is beyond the time where damage can be done. So encouraging people, especially if they have loved ones who are using opioids, or loved ones that even have opioids in their house, it's important to have naloxone on hand just in case you need it. When I talk about naloxone, I talk about it as a fire extinguisher. You hope that you never need to use it, but in the case of an emergency, it's there. And so that's one instance where you would need more than one dose, is if they don't respond to the initial dose. Another important thing to understand is naloxone does not stay in the body for very long. It can stay in the body for 30 to 45 minutes. If someone has used large amounts of opioids, the naloxone may wear off, and they may still have opioids in their system that could cause the person to go back into an overdose. So if that were to happen, administering another dose of naloxone is necessary. And also that's another reason why someone should go to the hospital and get treatment after an overdose, just to ensure that they return to their usual breathing rate, and they're out of the woods per se. So anyway, naloxone is available over the counter. As long as it's stored at room temperature, you can get 2 years or more out of its before it expires. Generally, if you have expired naloxone, that's better than not having naloxone at all. And if it's been stored appropriately, it's likely going to be effective beyond the expiration date. But if you need a replacement naloxone, pharmacies have them, or other public health organizations, other harm reduction organizations usually will disseminate naloxone without a charge. So before I go on to my next slide, I want to make sure or answer any questions that may have popped up here. Let's see.
There is a comment right now, but I think that we can leave that towards
Okay.
the next slide.
Sure. So anyway, I think, as you can see from the amount of overdose deaths, we are not really winning this opioid epidemic right now. And one evidence-based tool to prevent mortality is to disseminate as much naloxone into the community as we can. So I think that if you have the opportunity to acquire naloxone, or if you want additional training, there are courses, there are classes, but I believe that what I've shared with you this afternoon is enough information to confidently use naloxone. The last thing I wanted to talk about, and you could spend easily hours on just this slide right here, but there are some options for people who develop opioid dependence or opioid use disorder. Of course, there are non-pharmacological options. We talk about getting to the root of why someone is using. We can do that through group or individual therapy, of course, and different types of programming. But another tool in our tool belt for opioid use disorder are medications for opioid use disorder. So we have methadone, buprenorphine, and naltrexone. And without getting too deep into the pharmacology of these three drugs, research, large reviews, systematic reviews, meta-analyses show that treatment with methadone and buprenorphine specifically reduce mortality in this population by about 50%. Now, across any disease state, we really don't have drugs that are that effective at keeping people alive. Maybe insulin for people with diabetes, but these medicines, if used appropriately and used in ways or timed and administered at the appropriate course of or the appropriate time of the use disorder, can be life-saving. So I do the best I can to promote these when I'm working with people. And we don't have that many options, but we have enough options that we can individualize treatment. And so it's not a one size fits all. It's not a one dose fits all, but there are certain regulations that make these substances more or less available. Methadone, which has been around for used longest in the course of history for opioid use disorder, can only be dispensed from something called an opioid treatment program, otherwise known as a methadone clinic. So these clinics oftentimes will have other services than just dispensing methadone. A lot of times they'll have counseling, and they'll have group therapy. They may even have a psychiatrist on staff. But usually methadone patients are required, at least initially, to come to the clinic every day, receive their dose, and then go on with their day. And the idea of methadone, and really any of these substances, is to stop craving, to get people back functioning and engaged in their day-to-day lives. Maybe that's repairing relationships, or going back to school, or getting a job. And these medicines oftentimes receive a lot of flack or stigma. You're just replacing one substance for another, and that's really not true. We're looking at functionality and well-being of the whole person. So if someone can take a medicine and not be impaired, not be overly sedated, not be high, and return to their usual functioning, and live the life that they want to live, then these medicines by no means are a substitution for recreational drug use. Buprenorphine and naltrexone have a little bit less restraints in terms of prescribing. They're available from primary care doctors, or really any physician that has the ability to prescribe a controlled substance. And these medicines can be very useful at helping people to refrain from using recreationally, and kind of getting back into the swing of things of their daily life. I would say that naltrexone, which is also available in a long-acting injection for Vivitrol, is a first-line treatment for patients with alcohol use disorder, but does require a period of abstinence from opioids for about 7 to 14 days prior to use of this medicine. So we have options, and there's more research ongoing about how to develop different formulations and different treatment options that can help to keep people engaged in their recovery, and essentially keep them alive. In the way that we practice nowadays, we're much less concerned with abstinence and more concerned with functionality and well-being. And I think that's an approach that if it's adopted across the country, we'll start to see an improvement in quality of life, even if we don't achieve abstinence fully. But anyway, as I alluded to, I could go on about these three drugs for several hours. So I just wanted to, for people who are not aware that there are medicines out there to help for opioid use disorder, I wanted to mention them briefly. So that's really all I have to say about opioids, but I'd be happy to discuss things further or take any questions.
Well, there is a question here indeed, and thank you, Aaron, for this very comprehensive information. Like, I think we started in a more negative note, but we ended up in a very positive note, learning that there is help available for people with addictions and addictions of opioids that apparently are very bad. So thank you so much for this overview. And here is a question: can we still use the sternal rod versus earlobe nail pressure? And I have no
Sure.
idea what that question is about. So if you want to
Yeah.
explain that, that'll be great too.
Sure. That's a good question. And a couple years ago, the American Heart Association released a statement saying if we could refrain from using the sternal rub, that would be preferable. If someone is digging into the sternum to try to arouse someone, trying to wake them up, you can really do a lot of damage doing that. Of course, if you've tried everything and you're out of options, your last line of your last attempt is a sternal rub, by all means, it's either that or the person has passed away, unfortunately. But to start with that initially may be a little bit too aggressive. But if you've gotten to the scenario where you've tried everything, you have administered Narcan and you're calling 911, that is an option. It's just no longer a first line recommendation.
And here is the story. It says many teens know they are consuming fentanyl and they might be addicted. There is the story of a teen who was using fentanyl and witnessed two of his friends overdose, and he was very fearful for his life. The person who wrote the message said, I was able to get him to detox at the hospital, but when he was released, he picked up again because he did not know how to get follow-up services.
Yeah. So I'm really sorry to hear about that that person's experience. Unfortunately, it seemingly is something that happens often. It's not always easy to get people into the appropriate level of treatment. There oftentimes is ambivalence about medications for opioid use disorder, where maybe people aren't necessarily against it, but they don't know enough about it and they're hesitant to begin treatment. But as I mentioned, this is very much an interdisciplinary approach to the patient. We can stabilize someone, we can detox them with medication, but the follow-up is really important. Fentanyl seems to really get a hold of people. It has a very short-lived experience, so it's on and off very quickly. But when it is on, it's a very intense euphoria, and people tend to gravitate to the more potent substances, even if they know that there's a chance that they could overdose and it could be deadly. The high is just incredibly powerful. So that seemingly is what draws people draws people back to the drug. In these scenarios, I think we have some options that could be useful. If the patient is not able to get an appointment with an addiction specialist and maybe they've begun treatment with medicines, we do have long-acting injectable formulations of buprenorphine that are becoming more available and more widely utilized. So that can sometimes bridge the gap from leaving an inpatient facility to follow-up care. But yeah, it's sometimes going from a detox directly to an inpatient treatment program or more of a long-term treatment program is necessary. But I certainly understand that insurance and cost and price of all of these different types of treatments can add up, and insurance may not allow certain levels of care. So it's a challenge for people, and I wish I had a better answer for it, other than just, I would say, if you're someone who's looking for services, to just keep trying. I think there's some websites. I believe SAMHSA, which is a mental health organization, may have like a buprenorphine treatment locator, or I know at the hospital we do the best that we can to refer people, but certainly it doesn't always work out. But I would just say to keep the hope, and if there is a desire to get treatment, to keep looking, and in the meantime practice harm reduction, try to keep that person safe and alive, and so they're able to find treatment.
Yes, and I feel that, if you ever need help and you want to reach out to Nyack Hospital, we are here. I've personally helped some people find services. It might not be at the hospital, because, correct me if I'm wrong, Adam, but the services that we provide at Montefiore Nyack are for 18 and up, right?
Correct. Yes, for 18 and up. And so yes, that certainly is a barrier. But there,
yes. But we know of programs that are for 17 and younger, so we can always help people get engaged, or families getting engaged with other programs outside of Nyack Hospital that might provide services for younger ages. But, we are your community hospital, so we're definitely here to help. Another question. There was an incident where a 1-year-old, and I knew this was going to come up, an incident where the 1-year-old died, and other children were hospitalized at a daycare center that was holding fentanyl. What are your thoughts on that?
Yeah, that's come up a handful of times here at the hospital since that happened. I think what it points to is the need for naloxone kind of everywhere. It's hard to say what was going on at that facility where they were housing so many or large doses of fentanyl, but for a child, a small amount would be enough to be deadly. So this again goes to storage. Even if you're storing a substance that's not a prescription, if it's an illicit substance or recreational substance that has the potential for an accidental exposure, keeping it out of the reach of children, keeping it locked away somewhere. But we're hearing more and more about these accidental exposures, and this case, of course, seems to be more on the extreme side. But either way, having naloxone around could prevent any serious types of events from happening, or at least hopefully mitigate the harm that had already occurred. Really, storage and having naloxone on hand, I think is most important to take out of this. But obviously there's more going on in this story than what is the norm. But either way, I think being aware of if you have a substance that is potentially dangerous, trying to keep as close an eye on it as possible and keeping it out of the reach of people who are vulnerable is important.
And Aaron, does naloxone have an expiration date? I think you mentioned that before.
Sure, it's a good question. And it does have an expiration date. Like if you look at the box, it will say that naloxone, this kit expires, usually it's about 2 years from when it's, disseminated. But I don't have a lot of confidence that, let me rephrase. I have confidence that if you attempt to use naloxone beyond that expiration date, it'll still be effective. So as long as it's been stored appropriately, if it's not and even if it's been in a car, I would still be okay with using it. But if there's a concern that this is expired, you can always get it replaced. But just that's how the drug is sold with an expiration date. I would view it cautiously, and not entirely disregard it, but at the same time, I do think you have several years of leeway beyond it. I hope that helps.
Yes, and I have just shared, something that was just shared with us as well, is a link to receive test strips to detect the presence of harmful additives like fentanyl and
Oh, yeah,
in the
of course.
unregulated drug supply. So
Yes.
it's in the chat. You can go there. Is oasis.ny.gov/harm reduction delivered.
And Sandra's referring to these fentanyl test strips here. So these are little dipsticks that you can test for the presence of fentanyl in a drug supply, and it reads positive or negative, just like a pregnancy test. So people can take small amounts of a powder. A tablet can be broken off and mixed with a small amount of liquid, kind of stirred around, and then within a few minutes, it'll read positive or negative. So as we mentioned, we're pretty confident that the heroin is going to contain fentanyl. But what we're not sure about is, does my cocaine contain fentanyl? Is this Xanax bar totem pole I purchased, does this contain fentanyl? And identifying that is shown to change people's drug use behaviors. But what we also know is that these are not commonly practiced by people who are in the depths of addiction. They usually are not wasting, or they're not using their time to test their substance before they use it. But that's something, as a healthcare provider, we can provide these. We can educate on the importance of knowing what you're using before you ingest it. And even if the person still goes on to use the substance, they may use with people around them. They may ensure that they have naloxone. They may do a test dose or a small hit of the substance to test the potency before they do their full dose. So I think these are really useful, and we're still working on getting them disseminated and used more frequently.
And Adam, lastly, because we only have 2 more minutes here,
Mhm.
because we could talk forever about this topic. I know at some point we were giving the naloxone kits for free. Is that still
Yeah.
the case? And if so, what do we need to do that?
Sure.
And if any of our participants from today would like to get one, what do they need to do that?
Sure, that's a really good question. So we have a take-home naloxone program where if someone is admitted to the hospital and participates in our recovery program, they will go home with a naloxone kit. Or another instance where we use this is if someone is in the hospital and they're prescribed high doses of opioids for pain management, we may send them home with an naloxone kit as well, just to be safe. In terms of if just someone from the public is interested in a training, I know NIAC's outpatient recovery program often will host trainings throughout the community. I'm not certain as to when the next one is, but that would be something to look into. And even if it's not associated with our hospital, a lot of times there are other public health organizations that are doing trainings, and they will, once you receive the training, you usually go home with a kit as well.
Yeah, and don't think that the training gets hours to do or anything like that. It's a very quick training.
Yeah, I mean, it could be done in 5 minutes.
Yeah, we have actually done this in street fairs and everything.
Yes, yeah.
If you are interested on having this training done, at your workplace or in your school or somewhere you think it might be useful to have, give us a call. Community Health and Wellness at Montefiore NIAC is 845-587-1318. And we can schedule how to go to your place, do these trainings, bring the naloxone kits, talk to anybody who we need to talk to that you think it's necessary about this drug use or abuse. And yeah, we'll take it from there.
Yeah, absolutely. And just see one last question. And I don't believe we're offering medication disposal bags, but I do think that that's a great idea to remove medicines from the medicine cabinet. I believe there's a National Prescription Drug Take Back Day, so that's another opportunity to dispose of unused opioids. You can also take your medicine to a pharmacy or police station where they have a disposal box and they can be discarded as well.
And here as well. So if you have any medications that you want to dispose of for whatever reason, you can bring in here to the hospital, to the security office. It's like to the left of the main entrance, you're gonna see a door that says security, and you can just leave all your medications over there and we'll take care of all of that for you. And it's 101. I can't believe it. I could keep talking about this forever, but thank you, Aaron. We gotta go. Thank you so much. Thank you to all of our attendees. Yes, I'll talk to you to bring you programs to your location, and very happy to be here. Don't forget to be here next week, please. And the topic next week is driving for resiliency. We're going to be talking about this mental health program on wheels that can go anywhere just to provide assistance to people with mental health disorders. So thank you so much for being here, Aaron. Mwah. You're the best.
Thank you.
Thank you
Thank
so
you,
much,
Sandra.
everyone.
Take
See
care.
you soon.